Welcome to the Pro Aging Podcast. I'm Steve Gurney, founder of the Positive Aging community. We're excited that you can join us for our interactive discussions with pioneers and thought leaders on a wide variety of topics related to aging and longevity. We're able to bring these discussions to you along with copies of the Positive Aging Sourcebook, thanks to the support of our Positive Aging community champions. Visit proaging.com to connect with them and find hundreds of other resources. Today, we learn about the PACE program, which is the Programs of All-Inclusive Care for the Elderly. And it serves individuals who are age 55 and older, certified by their state to need nursing home care, but they're able to live safely in the community at the time of enrollment. So even though they qualify for nursing home care, they are living in their home. And they must be within one of the PACE service areas. So let's jump into an informative discussion with Peter Fitzgerald. He's the Executive Vice President with the National PACE Association. Record. And I'm going to let our YouTube and LinkedIn folks in. All right. Well, today's discussion is going to be a good one, and the reason I know it's going to be a good one is that we have had the request to have this discussion quite a few times, especially when we're talking about caregiving or money matters or what have you. The PACE program, the Programs of All-Inclusive Care for the Elderly, is something that is commonly referenced. And I am delighted to have Peter Fitzgerald, who represents PACE programs nationwide, to give us a glimpse at what these programs are all about, and then help us understand how we can work with ourselves, our clients, and our families. So without additional fanfare here, let's welcome Peter to the stage. And Peter, welcome. And thanks for joining us today.
Thanks for having me. And I appreciated your preview of coming events. It's a great lineup. I'm kind of like, who needs Netflix if you've got positive aging? You got a lot going on.
Yeah, I think there's some people there's some people out there, the phrase that we hear more often than not in this field is "I'm not ready yet." So there's a lot of people, even though we've got great content, they do not want to watch it or tune in. But sooner or later, we all have a crisis situation, whether it be in our family or our profession, and I'm glad that we've got these resources out there. Peter, before we dive into the PACE program and learn more about that, let's get a little bit of info on your background. Tell us a little about what led you to your current role there with PACE.
Great, thanks, Steve. So I've been working in long-term care pretty much since the beginning of my professional life, and I guess you could say working in caregiving from the very outset. My first role was actually with a childcare company that was interested in providing childcare in the work site, which is such an important service for working families, and that was interesting. But then I had an opportunity to move over to work with some nursing home payment and quality reforms through a national demonstration program. And I found that to be very meaningful to me. I was always very close, in particular, to both of my grandmothers. My grandfathers died relatively young in age, but both of my grandmothers were very real mentors to me in my life. And I was interested in working on a program that could make their later years better. And at that time, this goes back quite a ways. I'll try not to divulge my exact age, but when I started working, people got their long-term care from nursing homes, and there was very, very little alternatives to that. So To put that in context, there were about 17,000 nursing homes when I started working in long-term care. I think there's about 12,000 now, with the availability of more home and community-based options. But my early work was with nursing homes, working with them on some quality improvement initiatives. And then I had the opportunity to go work with a managed care trade association, so the Association of Managed Care Organizations. And when I got there, I was surprised at the lack of focus. This was, again, before Medicaid managed care really started looking at long-term services and supports. But I was surprised at the lack of focus, not only on the care of older adults, but on chronic conditions as well. But I got the opportunity to work on some quality improvement programs there related to diabetes, congestive heart failure, and asthma. And then most recently for me now is about 20 years ago, went to begin working for PACE, Programs of All-Inclusive Care for the Elderly, which for me was in some ways a natural transition because it was long-term care using some managed care principles, but really implementing a lot of the best of what I think we would all like to see in the healthcare system: coordinated care, community-based care. It's a comprehensive care model, and we may want to get into that a little bit later in the Q&A. But basically, it's a model of care that takes responsibility for meeting all of not only the healthcare needs, but the support care needs of individuals, and does that in a very flexible, comprehensive way. So I was really excited to go work at PACE. I've been working at the National PACE Association now for about 20 years. Almost all of my time there has been looking at how to expand access to this program, which really is, if you talk to people in long-term care world, it's often cited as the gold standard of care. It embodies so many of the attributes that we would like to see in healthcare. And that's the work that I continue to do.
Wow, it really sounds like your career really led you in the right direction. And one of the things that I see commonly, like when I'm in a discussion or on a panel or looking on social media, there's seems to always be such high regard for PACE and what you all are doing. And oftentimes it's like, someone will comment, well, how did I know that it wasn't there? And we can dive into that a little bit deeper, but let's start with the fundamentals. What is the PACE program like? And then we can talk about who qualifies and how we take advantage of it and what have you.
Yeah. So the PACE program began almost 50 years ago in San Francisco as an approach to serving older adults in the Chinese American community. And for that community, they really did not want to send their older adults off to the nursing home. They wanted to find a way to keep them at home. And it began as essentially an adult day health center, a place where you could bring older adults during the day, and they would get some care and some food. What they quickly found out was that people were going to the hospital or ending up in the nursing home due to a lack of coordinated care that encompassed primary care, rehabilitative services, nutrition, transportation. And so this first program called Unlock, which in Cantonese means peaceful, happy abode, gradually added services in response to the needs of the older adults that they were taking care of. And at that time, there was no national platform to do that. The flexibility simply didn't exist in the financing system or in the delivery system. So Unlock started out as a demonstration program under Medicaid, which is called Medi-Cal in California, and under eventually Medicare, where they said, since there's no way to do this within the existing fee-for-service healthcare system, can you just give us a flat monthly amount of resources, and we will use those flexibly to meet the needs of our population? So I always like to point out that even though I think many people are familiar today with capitation because they're familiar with it in the context of a managed care organization, for example, the origin of capitation in the PACE model was a desire to more flexibly meet and respond to the needs of the individuals, because the fragmented healthcare system and payment system didn't allow for that. So one feature of PACE that is good to keep in mind is we're a capitated program. So we are not subject to the financial incentives and perverse, in many cases, disincentives to provide the right care. In fact, we have always found that when you're caring for an older adult population that is comprised of individuals, all of whom need a lot of care, the most cost-effective thing we can do for them is provide them good care, prevent a fall, prevent them from going to the hospital, give them the nutrition they need. So exactly the kinds of things that traditional healthcare was never set up to do are things that have always been prioritized within the PACE model. So PACE provides all Medicare and Medicaid covered services for the individuals in its care. And as I was just referencing, in addition to those covered services or mandatory covered services, we can do a lot of other things. So we provide transportation. One of the favorite stories in the PACE community is there have been participants who have had a pet as their primary companion. And if that dog had fleas, the PACE organization can pay to get the dog treated, eliminate the fleas so you don't have a skin condition, which can lead to a hospitalization. So a lot of flexibility in the way that we think about the care plans that we put together for individuals, really trying to address their needs holistically. And pretty much anything that person needs, the PACE program is responsible for. One element, and it's important, is that we're not funded to provide is housing. So we do work to provide supportive services in housing, but we're not actually paid to be a housing provider. And of course, we all know, housing is such a fundamental part of being able to live healthfully and being able to live in the community. So we work closely with affordable housing providers, but we're not a housing provider under our PACE program itself. And maybe that leads to, a description of who we're primarily serving. About 99% of people in PACE right now are Medicaid eligible. 90% are Medicare and Medicaid eligible.
Okay. And it's just, this is a good opportunity for us to give an overview if you're not familiar with these two programs, but Medicaid is a program for the impoverished. Okay, so in general, and there's exceptions to this, especially if you're married, you're down to like $2,000 in assets or so. And then Medicare is the health insurance program for people over the age of 65 or people with disabilities. Did I do an okay job of describing that?
Yeah, exactly. And unfortunately, in our current system, the only public financing for long-term care is really Medicaid. So the system often requires people to spend down all of their income and their assets so until they qualify for Medicaid. And I think Steve, you may be more current on this than I am, but I think nursing home can easily cost $9,000-$10,000 a month. It doesn't take that long for most people, and I'd actually love to delve into some of what we're doing to try and make PACE a more affordable option for those middle income people who currently would find it difficult to afford.
Okay.
But just to round out the description of the program, it's a fully comprehensive program, and I just wanted to give folks a sense of how care is delivered. PACE programs have a PACE interdisciplinary team. It consists of primary care, social work, nutritionists, occupational physical therapists, speech therapists, really all the different disciplines that would be involved in an individual's care. That team, when someone first comes into the program, assesses needs and develops a care plan. That team continues to monitor the health of the individual on an ongoing basis. They meet every morning, and they will focus in particular on whether or not somebody went to the hospital or had a fall, or if there's anything they need to do to intervene that day. In addition to the team, PACE organizations operate a PACE center. The PACE center is a place where there are activities and meals. It's also where the primary care clinic is located, and the OT-PT speech therapies are provided. PACE programs offer transportation, so they pick people up in their homes, bring them to the center. They will also bring them to specialists if the individual needs to see a specialist. And we are providing care in the home. So we're providing that assistance with activities of daily living like dressing or eating, so that people can continue to live at home. And I would just say that we're able to do this for a wide range of needs. About 50% of the people in PACE programs have some form of Alzheimer's or dementia. So we are caring for people who deal with that added complication to their aging. And we're providing support to their family members as well, who are acting as caregivers so that they can continue to live at home.
Okay, I got lots of questions, and I know we can dive in deep, but our audience is got a bunch of questions, and especially on qualifying. And so one of the questions was, is PACE a needs-based program? And then Michelle said, so over 65 is needs-based, and most participants are needs-based via Medicaid. Norma said individuals must qualify both financial status and level of care. So tell us a little bit about how we can qualify.
Right. So PACE is unusual in the sense that, and I personally take some umbrage at this, but PACE actually includes people 55 and older. So it's called the program for the elderly, but it does reach down as young as 55. And actually one of our fastest growing enrollment segments is that 55 to 64-year-old population. And in that population, we tend to see more people with some kind of physical disability that they might have had for most of their lives. So the criteria to enroll is 55 and older. You have to meet your state's criteria for needing a nursing home level of care. And that's typically you have to have multiple chronic illnesses, as well as need for support in the basic activities of daily living, which I mentioned earlier. You have to live in a PACE program service area. So PACE programs, because we are direct providers of care, our locations of care need to be accessible to folks. So we typically serve a geographic service area that might encompass about a 45-minute driving radius. So you have to live in that service area. And at the time of enrollment, you have to be able to live in a community setting. It doesn't, if you subsequently decline in status and you have to be in a nursing home, you don't get disenrolled from the PACE program. It continues to care for you. But at the time of enrollment, you have to be able to live in a community-based setting. In terms of financial eligibility, for Medicaid to pay for your care in PACE, you do have to be financially eligible, and Steve did a nice job of describing those levels. But you don't actually have to be eligible for Medicaid to enroll in PACE. PACE is a Medicare benefit. Every Medicare beneficiary in the country is entitled to PACE. The reason we don't see many people enrolling as Medicare onlys is the cost barrier. And I'm going to take this opportunity, if I could, Steve, to highlight something we're working on, which is the Part D prescription drug cost barrier to enrolling in PACE.
Yeah, and I'm glad you did this, because Michelle asked the question, what is the cost for those that are not needs-based, or I guess Medicaid?
Right. So there are no out-of-pocket or copay or deductible costs in PACE. Once somebody enrolls in PACE, there are no copays or deductibles. So the form of payment for the individual is in the form of a monthly premium or capitated rate. And there are two of those. One is for the kind of care that Medicare doesn't cover. So long-term supportive services, in-home care, adult daycare. And that rate is based on what the state Medicaid program pays the PACE program. So instead, you're going to pay it out of pocket, and you're going to pay the exact amount. A good sense of the average cost of that would be about $3,500 a month. The other amount that individuals will pay, again in the form of a premium or a monthly flat rate, is for their Part D prescription drug coverage. PACE organizations are currently required to offer Part D prescription drug coverage. And if you enroll in PACE, you're required to get your prescription drug coverage through the PACE program. I'll try not to get too into the weeds on this, because Medicare reimbursement around Part D is very complicated. But due to an anomaly in policymaking, PACE organizations do not receive any of the subsidies that other Part D plans receive from Medicare. So we do not get a Medicare subsidy, and we do not get mandatory drug manufacturer subsidies that all other Part D prescription drug plans get. As a result, we have to pass those costs on to the individual, and our Part D drug plans cost about $1,000 a month. That is significantly higher than what you can get on the market. So where it might be about $40 a month. I'm going to put in a little plug for some legislation that is in Congress right now. It's called the PACE Part D Plan Prescription Drug Choice Bill. It has been introduced in a bipartisan manner in the House and the Senate. If anybody on this call would like to see PACE be more affordable for Medicare-only individuals, I strongly encourage you to contact your senators and representatives and ask them to co-sponsor that bill. It's bipartisan. We think it has a good shot of passing this year, but we are trying to drive additional co-sponsors towards it. But just to say a little bit about what that bill would do, it would give the Medicare-only individual the choice of taking the PACE Part D plan. So if you want to do that, even at its higher monthly cost, maybe it's appealing to you because it has no copays and deductibles. Or it would give you the option to choose a Part D plan on the marketplace, which might cost you $40 a month instead of $1,000 a month, and you would have some copays and deductibles. That marketplace plan would also not be affiliated with the PACE organization. It would be independent of it. We've done some modeling, Steve, and we think for most people, choosing the marketplace Part D plan would bring their prescription drug coverage down to about $500 a year instead of $12,000 a year. Wow. So we see that as a major financial barrier to Medicare-only folks enrolling in PACE, and this bill would fix it.
Excellent. Okay. Bunch of great questions here. We're going to get to all of them. One thing that I want to do before I jump on a couple of these questions here is share the website on my screen, and I added the link in chat there. But the reason I wanted to do this is you'll see on the first page of the website, it says find a PACE program. And this is where you can find, the various programs around the country. And as we can see, there are you don't have programs in every state and every geographical boundary. Are there programs in development in some of the states?
Yeah, there are. We currently have 131 programs serving about 70,000 people. That's a relatively small percent of the total people who might benefit from PACE services. I think there's around 12 million people in this country who need long-term services and supports. We are starting to see a lot of growth, and our objective at the National PACE Association is that there be access to PACE across all locations in the country, at all income levels in the country, and for all different kinds of communities, cultural, linguistic, and ethnic communities. And so we're working in a very focused way on expanding access. We're starting to see, particularly after COVID, which highlighted some of the strengths of the PACE model, specifically during COVID, people who were in PACE, all of whom, remember, are at a nursing home level of care. We had about a third the infection rate of nursing homes, a third of the death rate of nursing homes. And we were able to overcome the social isolation that many people face by continuing to have PACE staff work with the people in their homes. So that kind of did shine a light. And there's actually a New York Times article. I encourage you to look it up if you can. I think it's called, the title is PACE, the Underdog of Long-Term Care, that talked a lot right after, or I guess towards the end of the pandemic about PACE. But I think what we're seeing is partly in response to increased interest from older adults and their families, and also in response to many healthcare providers looking for new ways to provide care, more comprehensive, more community-based ways. We are seeing an uptick in interest, and we're also seeing that in states. So very excited about some developments in Illinois. Illinois is planning on adding, I believe it's 8 new programs. Ohio, which has had 1 program for over a decade, is planning on adding 5. We're seeing new programs come up in New Jersey, Maryland, Louisiana, and some conversations, if any of you live in the states of Nevada or Connecticut, the Connecticut legislature just passed a law calling for its state to study and proceed with PACE. There's no PACE in that state right now. The Nevada legislature has been looking at this for a while, and I think it's actively right now doing some fact finding. So that's a good state to be active in. But yeah, I'd say generally, Steve, I think things are moving in the direction of more access, and we're working hard at NPA to support that.
All right, great. Well, let's dive into some of these questions. And one, which I'm curious at your thoughts on this, is Craig asks, given the value of PACE, why are there so few participants? Is that he looked up that there's less than 60,000 nationwide. Is this just awareness, or what do you think is limiting the numbers? Because it just sounds like a wonderful program.
Yeah, I think we're currently at about 70,000. So okay. But that's still, as I said, nowhere near enough. And I go back to my history when when everybody got their care from a nursing home, we needed 17,000 nursing homes. If we're going to allow a substantial proportion of people to get their care from PACE, we're going to need not 100, or we're currently at 151 PACE programs. We're going to need thousands of PACE organizations. So I think part of my answer is supply. We just don't have enough supply out there to meet the demand. But the questioner is right. I think a lot of it is awareness. And that's because the healthcare system is designed right now to channel you into familiar forms of care. So assisted living is there, nursing homes are there. Increasingly, enrollment systems in states and in Medicare channel you into Medicare Advantage or a Medicaid managed care program. Those systems are not designed to channel you into PACE, which is sort of PACE doesn't fit in any particular bucket. Where if you think about my description of how we deliver care, we're a direct provider of care. We have primary care physicians, we have nurses, we have social workers. So in that way, we're like other providers of care, but then we're also an enrollment option. So we're something that you enroll in to get all of your Medicare and Medicaid covered benefits. So in that way, we're sort of like a Medicare Advantage plan or a Medicaid plan, but we're actually neither. We exist in this kind of middle space, which I argue is ideally designed for the care of older adults. But the healthcare system is not designed to help people find PACE. So I think that's part of the answer. But definitely we have to work on supply, and we've seen an uptick in the number of new programs. We also see existing programs expanding, adding PACE centers, expanding their geographic service areas, but we've got a lot of work to do. I'll just take one quick second to thank. I want to thank some foundations that have been working with the National PACE Association on this very question. The John A. Hartford Foundation, Harry and Jeanette Weinberg Foundation, and West Health have been funding NPA for a project called PACE 200K, which is our goal of having 200,000 people be served by PACE by 2028. So and through that, we've been putting in place a lot of these growth ideas.
Wow. Yeah, that sounds fantastic. Okay, so someone asked, who administers PACE? Is it DHHS? But but I am kind of curious as well. Are you a nonprofit, a government agency, a hybrid? What type of organization?
Yeah, so it's important to distinguish the National PACE Association, where I work, from the actual PACE providers. So the association is an association of independent providers. 80% of those providers are nonprofit healthcare providers. Some are standalone, others are sponsored by healthcare systems. We have healthcare systems, hospice programs, area agencies on aging, federally qualified health centers. All of those types of organizations sponsor PACE programs, again, locally at the community level. About 20% of PACE organizations are sponsored and operated by for-profit entities. Those tend to be more standalone PACE organizations, so not for-profit healthcare systems, but for-profit organizations that developed in order to offer PACE services. They also tend to be more multi-location programs, so they'll have PACE programs, different cities and communities. Does that answer the question, Steve?
Yeah, I think it does. Okay. And let's see. Someone says, after decades of experience, what innovations and tweaks are now needed to help keep PACE on pace with the the needs of the future. Are you finding that you're utilizing any technology or innovation to help support the elders in their homes?
Yeah, definitely. And I think so COVID actually highlighted, during COVID, it wasn't safe for us to bring our participants, which is what we call people who are enrolled in PACE, to bring them to the PACE Center. And typically we would have done that 2 to 3 days a week. They would have come in, activities and food, and maybe seen a therapist or a physician. It wasn't safe to congregate people. So we switched our technology. We offered more care in the home. We were doing telehealth visits. Some of our programs actually repurposed the vans that we used to transport participants to the center. They repurposed those into mobile health units, and they would arrive at the house or at the housing community and deliver primary care right out of the van. So we started using those kinds of care model adaptations during COVID. And I think many people saw the value of those beyond COVID and are retaining them. So I think coming out of the pandemic, increased use of telehealth visits, looking for ways to support people if they can't come to the center or don't want to come to the center. A technology that we used was sort of a simplified iPad or personal digital device that allowed our participants to stay in touch with one another, because for many of them, their friends, their social circle are the people that they get to know at the PACE Center. Outside of technology, for some time now, PACE organizations have been looking at how to expand their capacity by working more closely with existing community services. So PACE organizations, in addition to their own staff physicians, can work with community-based primary care physicians to provide primary care. And in addition to their own PACE centers, can work with existing adult day health centers or other locations, such as a senior meal location, to provide care in those settings. So looking at how we can broaden the settings of care where we operate.
Excellent. Okay. Aubrey says, are you aware of any federally qualified health centers that also operate a PACE program?
Many actually. I think currently we're up to about 12 or 14 out of the, so about 10% of the PACE organizations are sponsored by federally qualified health centers. And we're seeing a lot of growth coming from federally qualified health centers, particularly in the state of California, but they are also in Massachusetts and North Carolina and I believe Indiana. So it's a great fit. FQHCs, which also started about 50 years ago, interestingly, when PACE did, and started primarily, in medically underserved areas to help women and children. Like all of us over those 50 years, that population is aging, right? So FQHCs increasingly find themselves taking care of older adults, and they're a primary care focused, community-based care model, which is a very good fit for PACE. So I'm very enthusiastic about the opportunities to expand access to PACE through FQHCs.
Excellent. And I dropped in a description of those, if you're not familiar with them, in chat. Let's see. You had mentioned satisfaction, and someone asked, is there a satisfaction rate that's been measured? And Norma, I dropped this into chat. She looked it up and she said that 94% of the Massachusetts PACE participants are very satisfied with their care. I'm assuming that for funding and growth and everything, you've done some research on the satisfaction of the program.
Yeah, the number of Norma sites is really consistent with our national figures as well. So we see over 90% satisfaction with the program. And we also did a survey of family caregivers because we know what an important role they play. And we found, I think it was 95% of our family caregivers would recommend PACE to another person, which is a key measure. They also reported feeling supported in their role as a caregiver. Very early on in my PACE days, I remember watching an interview with a woman whose husband had a major stroke, and she had been caring for him on her own. And she said one of the things she liked about PACE was it didn't seek to replace her in her role as caregiver, because that was a role that was important to her as a spouse. but it did support her in her role as a caregiver, allowing her to do what she could do without it overwhelming her. And I think that's such an important benefit of PACE. And I know there was a question earlier around support for caregivers. And I think, too often we think of caregiver support as kind of like, well, let's get people together and talk. And I think that kind of emotional support can be helpful as well as education. It's not a substitute for the day-to-day real support of taking some of the burden off the individual of saying, we can help. And that can come in big ways and small. The PACE interdisciplinary team can help simply by keeping tabs on all the different medical care issues, support issues that the individual is dealing with. So just, not having to coordinate all of that scheduling, or this doctor said that, and that specialist said this. The PACE interdisciplinary team is taking all of that information in. And I think just that alone can be a huge relief. But also just, sending in a nurse assistant to help get somebody dressed in the morning or help them get bathed. PACE organizations do laundry at the PACE center. So when the individual comes in, if they're unable to do their laundry, PACE organizations can do that. So I think it's just this very practical kind of caregiver support that can make a big difference for families of PACE participants.
Excellent. Okay. Let's see. Well, we have a lot of providers that are on the call today. And Jacob asks, so I host a day program. Could I partner with a PACE organization to offer this to PACE members? Like what would be involved with an adult day program like Jacob, either being a partner or like a PACE site?
So as a partner, Jacob would contract with the PACE organization to provide adult day services. I'm not sure what the range of services he provides. And the PACE organization, if there was a PACE participant who maybe lived close to that center or might already be affiliated with that center, might have been there, was doing okay, but now needed a little bit more help, and that's where their friends are, and that's what they know. So the PACE organization might want to contract in that way. In terms of becoming a PACE program himself, there's a whole application process. It goes through the state initially and then up to the federal level. And it brings with it that the sponsoring organization is able to provide all of the services that I've described earlier. So you'd really have to broaden the range of services that you were willing to accept responsibility for.
Okay, great. Okay. Alice has a great question. And I know we've talked, you're from the National Association and there's individual organizations providing care, but she asked, what training do PACE caregivers have, and are they paid directly from PACE? Where how does all that work?
So our PACE caregivers, if they're nurse assistants or nurses themselves, they all have their professional licenses. PACE organizations do a lot of training around how to be a member of a PACE interdisciplinary team. This is not something that is naturally a part of individuals' practice. They start out in their own scope of practice. PACE organization staff are required to be familiar with the care of older adults, which older adults have different kinds of care needs. So there's training around that. And I know many of our PACE organizations have offered training to their primarily physician staff around end-of-life care and hospice care. So PACE, even though you can enroll in PACE as young as 55, our average age is in the 80s. I think it's around 82. And the average length of time that somebody's in a program is 3 to 5 years. So people are spending the remainder of their lives in our program. So they're experiencing end of life in our programs. And one of our goals, which is consistent, I think, with most people's goals, is to the extent that we can, is for them to be able to die at home, to end their lives at home. And we have a very high success rate of doing that.
Yeah. And, the fact of the matter is that most nursing homes are short-term care. Like the fact that this average 3 to 5 years really is showing that this is an appropriate long-term care situation. Most of us, if we do go to a nursing home, it is for rehab and then we're discharged. So that's pretty cool. Sid has a question. So an individual in a PACE program does not have a choice of medical providers. For example, someone may no longer have the doctor who they had a relationship for years and instead have to adjust to somebody entirely new, or will PACE attempt to keep the same providers for the individual? Great question, Sid.
It is a great question. And Sid, I'd say originally in the PACE model, everybody got their primary care from the PACE primary care team, which in our primary care, we have physicians, nurse practitioners, physician assistants, and RNs. More recently, with a change in regulation, PACE organizations are able to contract with what we call community-based primary care providers. So it's not necessarily a PACE physician. It could be the physician that you're already seeing. So we can do that under a contracted arrangement. And if we do that, that physician agrees to join for the participants in their care to join the PACE interdisciplinary team in care planning and needs assessment and be an active member of that. The other arrangement that I see in some PACE organizations is they will arrange for a transition period. So if you're concerned that by joining the PACE program, you're going to lose that continuity with your long-term primary care physician, the PACE organization will pay for you to continue to visit that primary care physician for some period of time. What we've generally found is because of the access and convenience and geriatric expertise of the PACE primary care providers, people tend to want to switch over. But we do want to be responsive to the concerns about the continuity and preference of individuals.
Okay, great. Here's an interesting question. What are the toughest issues faced by rural areas if they want to start a PACE program? And do you find these programs are in a mix of rural and urban, or is the first wave of these primarily where the population is?
Yeah, great question. And this year, the National Rural Health and Human Services Advisory Commission, which is an advisory commission to the Secretary of Health and Human Services, the federal government, did a deep dive on PACE in rural areas to look at how to expand access to PACE in rural areas. I'd say we have about 20 PACE organizations serving in whole or in part a rural area right now. And one of the challenges there is that the population density is less, the travel distances are more, and that can make it difficult for a program to be viable. However, I think you contrast those challenges against the need. We also know the needs in rural areas are greater. There are fewer community-based options. In many rural communities, there's not even a nursing home anywhere close to where people live. So the need is great. And we've seen in some of our PACE organizations that serve rural areas very, very high levels of people choosing PACE. So just to put that in context, in most PACE service areas, PACE organizations are serving about 10% of people that we estimate using census data might need some kind of long-term care. There is a program that's serving rural Northern California, and they're serving well over 50% of the people in their area who need some kind of long-term care. There simply aren't other options. People are desperate for good care, and PACE is offering them a community-based care model. To get at the challenges, I think the challenges are that distance, that low population density. PACE organizations are working to optimize telehealth so that we can do specialist consultations through telehealth, some primary care consultations through telehealth, looking more and more at shifting from PACE center attendance into home services. I mentioned that earlier. And I want to link this back, though, to making PACE affordable to Medicare individuals. If PACE was affordable for everybody in the rural community, not just the low income part of the population, PACE programs would be viable in many more areas. So particularly in these rural areas, it does not make sense to segment PACE off for low income people. It doesn't make sense in terms of the viability of the PACE organization, but it also doesn't make sense in terms of the population living there. They all, regardless of income level, need this option. So one of the strong recommendations from this advisory commission that I mentioned was to address affordability of PACE in rural areas. And they did note this Part D issue as a major cost barrier.
Great. Pharmacist who I recognize on our discussion here, Emily Shoemaker, asks, does PACE provide medication management services in the members' homes?
Yes, PACE, a lot of actually medications are delivered to the individuals in the PACE center. So I mentioned typically coming in 2 to 3 days a week. And so they get, well, first of all, we do polypharmacy management right up front. One of the first things that happens when someone comes into a PACE program is the physician and consultant pharmacist sit down and say, show me everything that you're on, so we can kind of eliminate polypharmacy where it's contraindicated. So that happens. But in terms of the dispensing of the medications, most PACE organizations do these sort of daily packs that for each day group the medications that you're supposed to take. Some PACE organizations have used sort of a telehealth dispensing mechanism where they put that in the participant's home and it will dispense the medications on a daily basis. All PACE organizations are required by Medicare to have a medication management program in place that reviews the medications that are offered. It's interesting, unlike most Part D plans, PACE Part D plans tend to not use formularies. So we don't have restrictions on the medications that can be prescribed.
Okay, great. And we've got a hard stop today at the top of the hour, folks. We got about 12 minutes left. So I'm going to try to go through some of these questions that we've got, and I'll try to get to all of them. But Amy has a good one. She says, why is the PACE program only available to nursing home residents? Will PACE programs eventually be offered to AL and IL residents who are aging in place? And I think this is one of the confusing things, Amy. I was confused at first. You need to be eligible to move into a nursing home, but the goal is that you don't go to a nursing home, that you're aging in place. I hope I got that right, Peter. But I do want to address what she's bringing up about assisted living and independent living, especially independent living, because there are so many low-income independent living communities with Medicaid qualified residents that need care and they can't go anywhere. Do PACE programs sometimes provide the services there in the independent living subsidized?
And your clarification is right, Stephen. I'll just try and put even a more fine point on it, because the language is confusing. To enroll in PACE, you have to be nursing home level of care. You actually do not need to be a nursing home resident. And in fact, very few people who enroll in PACE are nursing home residents at the time they enroll. And if they are nursing home residents at the time they enroll, there has to be a plan in place to move them to the community more or less immediately. So again, going back to, in order to enroll in the program, you have to be nursing home level of care, but able to live in the community at the time of enrollment with the benefit of the PACE organization services. So that last piece I just point out because there are some people who would not be able to live in the community if they didn't have access to PACE, but with access to PACE, they can. So that's correct. We're not currently able to serve people who are lower than the nursing home level of care, and that's because of Medicare and Medicaid regulation. So we're just not allowed to enroll them since we are a Medicare benefit and a Medicaid benefit. Those two programs can limit who we enroll, and one of the limitations they put on us is that they only want us serving people who are at a very high level of need. There has been some legislation considered in Congress. It's not as far along as the Part D legislation that would require the Center for Medicare and Medicaid Services to allow states to offer PACE to people at lower care need levels. So that's something that may be in our future, but currently we can't do it.
Okay, great. Let's see. Okay. Bunch of great questions in here, folks, and I'm going to make sure that we add this in. Okay, let's see. Barbara said, "Did you say Medicare only members pay $3,500 a month?" When you're talking about Medicare only members. So somebody that is not qualified for Medicaid, they would be essentially like PACE would be sort of like a private pay type provider.
That's right. So it'd be $3,500 a month for the long-term service and support component of care, and probably about $1,000 a month for the Part D coverage. So add it all together, $4,500, $5,000 a month.
Okay.
I
still
think
less than a nursing home, but still probably more than, folks are what we refer to as the forgotten middle can budget.
That's right. And the other thing is, if you're not going into a nursing home, there's some costs associated with maintaining your home.
Yeah.
So
who decide? Michelle asked, who decides if the client is eligible? Is it a doctor, or is that you apply for the individual PACE program and then they have a committee or a process for?
If you're eligible, if you meet the nursing home level of care criteria that your state sets, and states create their own programs, and these vary by state for determining that you are at that level of care. So often there'll be a state agency, or the state will contract with an agency. Some states do allow individual physicians to complete a health assessment, but that's determining that you are nursing home level of care is separate from what the PACE organization does. If you are nursing home level of care, then the only thing then you are eligible to enroll in the program, unless the PACE organization determines that it is not safe for you to live at home at the time of enrollment. And that can be for a variety of reasons. Some people live in very unsafe conditions that have nothing to do with their health. They're sort of violent or dangerous conditions. But it could also be, for example, if somebody needs to be on a ventilator 24/7, that's not somebody who is necessarily going to be able to live at home.
Excellent. Okay. And several questions on contacting you. I hope it was okay that I share your contact info. Okay. Yeah. I dropped that into chat and what have you. Let's see. So PACE programs face all the challenges that all senior caregiving organizations are facing: hiring, training, paying a proper wage. Sid has a question. So does PACE pay a higher wage to caregivers to prevent employee overturn, or what's the method to that madness? Because it's a challenge everybody's faced with.
Yeah. We have certainly not been immune to those workforce challenges, and we're looking a lot at this. I think PACE tries to pay a competitive wage, but because we are financed by public payers primarily, Medicaid and Medicare, we're living within the bounds of those reimbursements. I think one advantage PACE offers, and we do see good employee retention rates, is just the continuity of the relationship that the healthcare worker has with the PACE participant. So, for example, if you're a home care worker, you're not just bouncing around from house to house, seeing different people. It's possible to have a longer term relationship. Similarly, in the PACE center, you're seeing people come into the center on a weekly basis. So I think there's some quality of life and quality of work appeal to working in PACE, but it's definitely been a challenge on the workforce front for us.
Great. Okay. It looks like we've got about 3 minutes until we have to end our discussion. So what I'm going to do is I've already had a bunch of requests. Can we bring Peter back? Or I think also, folks, what I'll look into is getting some PACE programs and maybe some families and participants in PACE programs to talk about their experience as a follow-up. But Peter, in any final closing remarks, and reminder to everybody, I tape this and I'll have all the chat and Q&A on the recording.
Yeah, I just want to thank you, Steve, for the opportunity to talk about PACE. I do believe, it passes the test for me. This is a program I would want my parents in as they age. And I think it's just critical that we make it accessible and affordable for a much broader range of older adults in this country. So I really appreciate the opportunity to talk to you, talk to folks on the webinar, and happy to follow up. Please, send me any questions, and I think Steve's given you my email address.
Yeah, this is great. Thanks so much, everybody. I mean, Peter, this is an amazing program, and you and your colleagues' commitment to it is fantastic. But thanks to all of you in the audience. I mean, that once again, the questions that you ask, I could have never have come up with it, but they're very thought-provoking and very served as a great platform for us to understand what PACE is a little bit better. So we'll see y'all at the next discussion, and Peter, I'll follow up with you and we can figure out some additional programming to offer here.
Perfect. Okay. Thank you.
You bet.